right, 4:01. I think we're going to get started. Thank you so much to everyone for coming today. Welcome to our event with Dr. Christine Montross, author of Falling into the Fire. Before we get started, I'd like to start with a few Zoom housekeeping items. First of all, you are all muted. If you would be able to stay on mute, that would help us a lot. This is being recorded and is also on Facebook Live, but you're able to turn off your video for added privacy if you'd like. We will have a Q&A at the very end. If you wouldn't mind typing your questions into the chat either now while during the event or even at the end during the Q&A, that would be fantastic. I will start us off with Frank Fendler, one of our board members.
Thank you. Thank you all for coming and welcome to this event with Dr. Christine Montross, author of Falling into the Fire. My name is Frank Fendler and I'm a board member at Connect Summit County. Our mission is to create a well-informed, stigma-free community with access to mental health resources for everyone. My journey with mental health began a little over 2 years ago when my son was diagnosed with schizophrenia. And shortly after that time, we almost lost him to this cruel disease. So for these reasons, I'm really passionate about Connect. And I also have come to understand that there's a lot for us all to learn and overcome. Before we begin, we want to thank Healthy You, Park City Community Church, Estee Pizza, Hyatt Centric, and Northwestern Mutual. Their generous support gives us the resources we need to make a big impact on mental health in our community in 2021. So we're excited to have with us today Dr. Christine Montross. Dr. Montross is a 2015 Guggenheim Fellow in Nonfiction and an Associate Professor of Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University. She is a practicing inpatient psychiatrist and performs forensic psychiatric examinations. She completed medical school and residency training at Brown University, where she received the Isaac Ray Award in Psychiatry and the Martin B. Keller Outstanding Brown Psychiatry Resident Award. Dr. Montross's first book, body of work, was named an editor's choice by the New York Times and one of the Washington Post best nonfiction books of 2007. Her second book, which will be the topic of our event today, Falling into the Fire, was named a New Yorker book to watch out for, and her latest book, Waiting for an Echo, was a finalist for the Los Angeles Times Book Prize. So please join me in welcoming Dr. Christine Montross.
Thank you so much, Frank. Thank you. It's really, I'm very, very happy to be here. Until I was invited to this event, I did not know of Connect Summit County, but I have learned a great deal about it since, and am really impressed by the community around it and the ambitious undertakings that it has, and how earnestly and steadfastly it seems to me that the organization is trying to help bring issues of mental health to the forefront and also to really make change and help for the good. So I'm really pleased to be a part of this event. I wish, of course, that we could be having this event in person. I think we're close as a physician and scientist. I think I really do see a lot of hope on the horizon, and I'm hopeful for sure that we're closing in on a time when we can be together in person. But until that time, I appreciate you taking time out of your schedules for yet another Zoom. I think my understanding of the format for tonight is that we're a small enough group that we really are hoping for this to tend toward the interactive at some point. So my role is to share a little bit about my work. I was telling the good folks at Connect that I prefer to do talks a little bit like a literary salon. I always tell medical students that we admit the most interesting people to medical school and then we beat the interesting out of them. And so many doctors and medical students and residents actually have these more creative sides of their brain. So it's fun for me to leave the PowerPoint presentation behind for a bit and do a talk where I talk a little and I'll read a little. And then I know that we're going to hear from some other voices in the virtual room tonight. And then our sincere hope is that there'll be a robust question and answer session at the end. We haven't really talked about how Q&As will be done, so feel free to correct me if I'm wrong, but I think people can put questions in the chat that we can look to, and perhaps if we're a small enough group at the end and people are inclined to unmute themselves and ask a question in person, perhaps that would be a possibility too. So we're looking forward to this evening together and this time together, and thank you for being here. To orient you to me a little bit, I work as an inpatient psychiatrist at a freestanding psychiatric hospital here in Rhode Island. There are not very many freestanding psychiatric hospitals left, and mine is sort of a relic of a bygone era in the best possible way. It's a really beautiful building that evokes when there used to be asylums, and the grounds were designed by Frederick Law Olmsted, the landscape designer famous for Central Park and Golden Gate Park, among other places. And one of the things that I love about my hospital is I think that although there were certainly many, many parts of the inglorious past of psychiatry that should have been left behind, I think what my hospital and the grounds reminds me of is that we've understood for a long time that a component of mental health is actually peace and quiet and tranquility, having an opportunity to go outside sometimes, be in touch with nature, not so much in a city hospital. So that's one of the things that I love about the place where I work. I work on units, they're called the intensive treatment units. They're sort of the psychiatric version of the ICU. So the people that I see are the most severely ill people in our hospital. They're hearing voices or seeing visions. Many of them are very manic, or they're actively trying to hurt themselves or other people. And I know that there are people in the audience tonight who, for whom those symptoms sound familiar, either from themselves or from love, excuse me, from loved ones. I love my job. I find it incredibly interesting. I find it incredibly rewarding. People often say to me, isn't that a depressing job to have? And I find it absolutely the opposite. The things that my patients endure and live through and then rise above often are incredibly inspiring. So I love my job, but in it, absolutely, I do see a great deal of suffering. And falling into the fire really came out of part of that witnessing of suffering. So I was a poet before I went to medical school. I had a master's of fine arts in poetry. I never thought I was going to be a doctor, but I was teaching high school English to a bunch of kids with a lot of psychosocial stress, and some of themselves with psychiatric diagnoses. And I found that I was really acutely interested in the things that they were going through. Many of them were prescribed medications. Some of them were really helped by the medicines they were prescribed. Some of them slept through my class and became sort of absent as a result. And I found that I was quite interested in trying to figure out I had had an interest in when I was writing poetry. I had been writing these kind of romantic poems about madness and the ways that the mind can derail. And then here I was seeing kids who were in absolutely not romantic situations at all, dealing with symptoms of mental illness. So I really became interested in how to actively become more involved in that field. I thought about doing social work or psychology, but seeing the way that these kids were medicated, sometimes for good and sometimes for ill, really helped me understand that at the moment we're learning a great deal about the brain. And if I wanted to know how best to treat people, whether that was medication or lack of medication, I might need to go to medical school. That was sort of a terrifying moment for me, but I actually entered into medical school knowing that I wanted to be a psychiatrist and have never regretted that decision. I really, really love my job. And so Falling into the Fire started as a book about maybe the 6 or 7 most compelling cases that I saw as a young psychiatrist. And when I say compelling, when I tell you that I was a poet before I was a doctor, it's partially because writing was always a way that I made sense of the world. And increasingly in medicine, as we've all experienced, whether it's in psychiatric visits or otherwise, you have about 10 or 15 minutes between patient and doctor. And as you know, 10 or 15 minutes is not really enough time for anyone to hear the stories of what a patient's going through, really witness the symptoms that they're experiencing, and then to think deeply about what you've learned about that individual person, right? And so for me, writing was an opportunity after I left the hospital to return to the cases that really gnawed at me, to try to give myself the time to think more deeply about these questions that were emerging for me as I was beginning my practice of psychiatry. In addition, as I was gnawing over those questions, their debates were raging about healthcare, going up and down the East Coast to different, really speaking about how I'm seeing a bunch of people pause, and I'm worried that I'm paused. Can someone just give me?
You were for a minute. It's
I'm
good
back on
now.
track. Okay, good. I don't want to be just talking and hearing no one. Okay.
I think people may have blackened their screens just to maybe give more bandwidth. I don't know, but
absolutely fine. But I got a little internet is unstable connection, and
yeah.
I thought I'd hit pause. Thank you. This is the Zoom era. Here we go.
Yeah,
but,
you're fine. Thank you.
Thank you. So as I was hearing people on the sidelines or on the train saying, that universal healthcare was bad for business or that it wasn't necessary, I was really aware how different my own experience was of what I was seeing in my patients. That what I was seeing over and over again was that my patients were ending up in the hospital with me largely because they didn't have consistent access to the outpatient healthcare that they needed. And I've thought a lot about how the way that we treat healthcare, mental health care in our country is very, very different, as we all know, from the way that we treat non-psychiatric medical care. But what I was seeing really made me feel as though it would be like saying to a patient with high blood pressure, we're not going to treat your hypertension as an outpatient, but if you're having a stroke, come to the hospital and we'll admit you to the hospital. If it's an emergency and you're having a stroke, we will do that. But then you'll leave and we're not really going to take care of and manage your hypertension when you leave. But if you have another stroke, absolutely come back. And that's what I was seeing with my patients, that they would be able to access care only when they were in very acute emergencies, that they would leave and they would fall away from treatment for a variety of reasons. Trouble with housing, trouble with finances, trouble with food, trouble with work, trouble with family, trouble with illness, whatever, trouble with access because there aren't enough providers. And then again, I would see them not too long later, but again, when they were in true crisis. So I started thinking, I think I have a different view of this than the people on the soccer sidelines. I think people don't really understand the struggle that many of my patients endure due to this kind of woefully inadequate outpatient care that we provide people. So those two things merged for me. My own desire to think really deeply about my patients' journeys and illnesses and experiences, and also a wish to try to share those, share what I was seeing and what I was struggling with as a clinician with readers. So with that being said, I'll read a passage for you about one of those encounters, and I think one of the central questions around these issues tend to be questions about autonomy and who has a right to really demand that someone gets treatment or really push for treatment, what happens when people don't want treatment. So this is about a 23-year-old young man who was brought to the hospital by his girlfriend who grew worried about him. He was behaving in a bizarre way. She said that he had been walking backward and walking in circles before picking up objects, that he said he described himself as sleeping without sleeping. And his parents had flown in from a different part of the country, and they thought that he was having some kind of a spiritual awakening, but they certainly agreed that his behavior was concerning. So that's where I met him. The medical school I was the medical student I was working with in the evaluation room walked in and gestured for Colin to follow. Colin did and stared at me. Then he stared with the same intensity at the empty chair to my left, and then at the locked window with no shade, and finally at the Monet poster encased in plastic and bolted to the wall. When asked to, he sat and smiled. "Hi, Colin. I'm Dr. Montross," I said, "and you've already met VJ, the medical student on our team?" If it's okay with you, I'm going to let VJ start, and then I might pipe in at the end with a few more questions. How does that sound? Sure, replied Colin. And then to VJ, he said, welcome. I could tell that the student wasn't exactly sure how to respond. Thanks, VJ stammered. Why don't we start by hearing why it is that you came to the hospital? Colin sat quietly for what was probably a minute, but seemed like much more. Then right when I was on the verge of repeating VJ's question, the silence broke. I'm having trouble communicating my life journey to others, Colin said. Tell me what you mean by that, VJ asked, leaning forward in his chair. Well, Colin responded, smiling, I think you know this. VJ smiled back, perplexed, then shrugged. Colin continued, the most important thing for all of us to know is that life is joy. I'm experiencing a soulful happiness, and I think it is hard for everyone to comprehend. As the interview went on, I jotted my own rough clinical assessment for the file. Wide-eyed, malodorous young man in tunic, unshaven, speech is slow, thought process is disorganized and circumstantial, content is grandiose. Patient denies auditory or visual hallucinations, but does endorse elated mood. Affect is expansive. Insight and judgment are poor, as evidenced by the fact the patient does not see the need for help. BJ finished gathering some final information. Colin had graduated from a prestigious college with an art degree. His senior thesis had been a series of huge metal sculptures. Since college, he had been employed on and off as a metal worker on construction sites to support his artwork. He had recently quit to spend a month following a woman called Amma the Hugging Saint through the western mountains of the United States. Amma's doctrine is love, he told me. She feels love for all people, and she provides comfort to those who suffer by hugging and blessing them. During the time he was with Amma, Colin had smoked pot and used some hallucinogens, but he said there had been no drug use for a month or more, and his clean toxicology screen from admission supported this claim. I had a list of potential diagnoses in mind. My first thought had been drugs, but given the result of the toxicology screen, that etiology was rather convincingly out. There was a remote chance that his symptoms were the result of exposure to some volatile substance in his metalwork, but his blood tests weren't indicative of any kind of dangerous solvent or heavy metal exposure. The other two options were either bipolar mania or a primary psychotic disorder like schizophrenia. In both of those conditions, medication would be the treatment of choice for an acute flare of symptoms like this one. Colin, thank you so much for sharing your thoughts with us, I said. I know you felt misunderstood recently, so we're going to work very hard to understand what you're experiencing. This was true, but it was also an attempt to navigate the complexities of trying to treat someone exhibiting psychotic symptoms without reaching too far into paternalism or worse, trickery. Frequently, patients are reticent to take medication. Sometimes their reasons are good and sound ones. Sometimes their fears are paranoid, their beliefs are illogical, or their minds simply cannot process the information fully enough to make an informed decision. I believed that medication could help Colin, and as a result, I tried to convince him to give it a try. I thought my best strategy was to talk to him about it in his own terms. We have some medicines that I think could help you communicate that experience more clearly. Colin looked at me quizzically. Why would I take medicine? He asked. I'm in love with the feeling I have right now. This joy is better than any drugs. And this is how our conversations went that morning and for the next few mornings. The nursing notes in the chart were similar from one shift to the next. Patient is pleasant, dreamy, and detached. He continues to pace on the unit or stand in place until redirected, refusing meds. A few days in, during our morning session, Colin began asking to leave. It's not that there isn't plenty to love in here, he said, gesturing toward a metal filing cabinet and then an institutional plastic chair, but I'm not sure how much longer this place needs me. It's easy in a situation such as Colin's to regard the institution of psychiatry as the authoritarian legacy of One Flew Over the Cuckoo's Nest, to think of psychiatrists as cartoonish egomaniacs who thrive on their ability to take away the agency of others, or who leave no room for divinity, for difference. Indeed, many patients who are admitted to my care reveal deep-seated fears that they will be stripped of their rights, medicated against their will, restrained, or sedated into the Thorazine shuffle. It may be tempting to lament the hospitalization of a patient with a heightened sense of connectedness and a new spiritual fervor. Indeed, Colin's case was even more ambiguous because he seemed to be more elated than distressed. Yet the costs and dangers associated with psychosis are tragically real. The famed author and neurologist Oliver Sacks pointed out the perilous allure of madness in discussing what he calls euphoric hyperstates, or states of ominous extravagance. Sacks cautioned us against ignoring, or worse, celebrating symptoms that seem to be happy but are a departure from a person's typical self. The paradox of an illness which can present as wellness, as a wonderful feeling of health and well-being, and only later reveal its malignant potentials, is one of the chimeras, tricks, and ironies of nature. In fact, a heightened good feeling, what George Eliot evocatively called dangerous wellness, can itself be a signal of sickness to come, more terrible still for its deception. Most of us cannot exist over time in a sustained state of exaltation. More often, a high is a sign of a crash to come. Many of the healthiest among us are familiar with that truth. For the mentally ill, the danger can be even more pronounced. The poet Robert Lowell, who endured both the excoriating manias and the debilitating depressions of bipolar illness, wrote, "If we see a light at the end of the tunnel, it's the light of an oncoming train." I chose that passage in part to read because I know that there are people connected with Connect who have been on that road of trying to help loved ones, trying to help themselves or the loved ones gauge when treatment is necessary, when it's not necessary, and how to preserve someone's own decision making in that process, which can be extremely grueling. And one of the things that's so different about psychiatry and mental illness as opposed to other illnesses, as many of you know well, is that the decision-making organ is the diseased organ. And that is one of the things that makes those questions and those decisions about autonomy and treatment so much more difficult. We know now that there are people who actually have advanced directives around their own mental health, where they will sometimes write down and say, if I'm exhibiting these symptoms, or if someone believes I'm unwell, this person has the right to admit me to a hospital. This person has the right to consent to me being medicated. But not all people do that, of course, and people's minds change over time as well. And one of the things I've been aware of in my work recently is attempts that family members often have to seek treatment can often end up in really catastrophic ways, that people may feel that the only chance they have to get the treatment for their loved one is to call the police if they're having a psychiatric emergency. This has been a subject of great interest to me recently, and as Frank mentioned, my most recent book, Waiting for an Echo, is about mental illness in the prison system. But I think one of the things that's been really highlighted for me in the current moment is this paradox that loved ones are often in when someone is having a psychiatric emergency. We know that people with mental illness are 16 times more likely to be killed by police than people who are mentally well. And one of the things that I've been thinking a lot about in this moment where we're having a real discussion around policing in our country, again, getting back to the example of the stroke, that when people are having medical emergencies in our country, we send trained clinicians to help them. We send EMTs and paramedics. And if you're in a car crash or having a heart attack, the people who come to you in that emergency are able to start IVs. They can stabilize a fracture. They can stop bleeding. That's not the case in a psychiatric emergency. That police are the first response when you call 911 to a psychiatric emergency. And it doesn't have have to be that way. We could send clinically trained people to respond to healthcare emergencies that were mental health emergencies in the same way that we send clinically trained people to respond to other healthcare emergencies. So that has been something that's been on my mind a great deal. And there's discussion nationally about a 988 number, like a 911 number. I think there's no single answer to this question, and we can certainly talk more about it in our discussion and in our question and answer. But I think there is a growing reckoning that a police response when someone is mentally ill is not the optimal response, and it can often endanger someone who's in a very vulnerable position. What I appreciate about conversations like these, like the ones that we're having tonight, is an opportunity to kind of chip away at the distinctions that people try to make between those of us who are mentally ill and those of us who are mentally well. And often in my work, either with severely mentally ill people, or now that I'm working some in the jails and prisons with detainees, it's a very common response where people try to sort of hold up a hand and say, like, those people are different than I am. And one of my goals in falling into the fire was to scratch away at that delusion, and to say that that we have a really shared humanity, and that shared territory is critical for us. But also we have a shared vulnerability that none of us, even those of us who perceive ourselves to be mentally well, are not promised immunity from mental illness. We're not promised immunity for our family members to be mentally well. So I like conversations like these where people with multiple perspectives come together, because I think this shared territory is really the place where forward movement can take place in some of these issues. So I'll read a little piece from Falling into the Fire that's meant to draw on that shared territory. When I was researching this book, one of the chapters that I wrote was on psychogenic seizures. So these are seizures that look exactly like a neurologic seizure, but are actually a physical manifestation of psychological distress. So someone can have a seizure that looks identical to an epileptic seizure, but it's really a psychiatric or psychological symptom. And I went to interview one of the leaders in the field, thought leaders around these seizures, thinking that he was going to give me all this like insight into how to really tell between the seizures and how to really diagnose them. And he did not. But what he did do was give me a term that changed the way that I practiced medicine. And he said that when he treats his patients, the term that guides him is abiding with his patients. And that term, which is not something that I think we associate with our medical care in America these days, is really not a term about fixing, curing. It's a term that really is about walking with someone, being with someone in their struggle, accompanying them through that, really looking at what they're dealing with straight in the face. And he was saying that when he feels like there's nothing that he can do, he can always abide with his patients. And I think for people with severe mental illness or mental illnesses that are really chronic, that idea of abiding with people really resonated with me and has been a real gift. So you're gonna hear in this passage that I reference that word, and you'll know now that it's not just a word, but it's something that's very dear to my heart. I also start with a little passage from a poem because I have my own origins in poetry. The poet Theodore Rutke endured episodes of severe depression throughout his life. His poem, In a Dark Time, reads in part, "What's madness but nobility of soul at odds with circumstance? The day's on fire. I know the purity of pure despair, my shadow pinned against a sweating wall. That place among the rocks, is it a cave or winding path? The edge is what I have. As a psychiatrist, I hear the stories my patients tell me, noble souls that they are, and learn how their circumstances are at odds with their lives. They come to me bruised and upended, and when they do, the trajectories of their lives seem to them to be at best uncertain, at worst doomed. If I am to abide with these patients, then I must accompany them to that place among the rocks, to the sweating wall. I must face with them the uncertainty of what lies beyond. I must stand at the edge with them and peer over into the fathomless depths. If I tell my patients, as I do, that this life can be a tolerable one, that they can face their fears and their traumas, their visions and voices, their misery, then I must look at what I am asking them to endure, and I must look at it full in the face. The French philosopher and Christian mystic Simone Weil wrote that to understand affliction, one must accept our total human vulnerability. I may lose at any moment, she wrote, through the play of circumstance over which I have no control, anything whatsoever I possess, including those things which are so intimately mine that I consider them as being myself. Standing on the edge with my patients, abiding with them, means that I must harbor a true awareness that I too could lose my child through the play of circumstance over which I have no control. I could lose my home, my financial security, my safety. I could lose my mind. Any of us could. A wonderful psychotherapist said to me in the wake of my having learned of my mother's breast cancer that we all live beneath a veil of invulnerability. For the most part, we act as if we and our loved ones will live forever. And then there are earth-shaking moments in our lives, a diagnosis, an accident, some unforeseen catastrophe, when the veil is pulled back and we see with clarity that we are all, in fact, perched upon a precipice. Mental illness pierces the veil, and those who suffer from it dwell with their fragility in plain view. My role as a psychiatrist is not to try to repair the veil, but to strengthen my patients so that they can live, so that they can suffer less, so that they can hope. Mary Weatherston is a psychologist who lives in Michigan. She is also a dear friend of mine. More than a decade ago, more than that now, when I was trying to decide whether to go to medical school to become a psychiatrist, I called her to talk to her about her practice. I worried, I told her, about what it would be like to deal with my patients' misery day in and day out. In retrospect, I think I was asking her how to abide with the suffering of others. Mary shares my love for northern Michigan and its lakes. Without thinking, she reached to that shared territory for a metaphor. The patients we work with have fallen through the ice in the middle of a frozen lake, she began. My job, your job, should you take this path, is to go out to them, to be with them on the thin ice, and to work with them to get them out of the frigid water. I listened as she continued. But you must know that if you go out to them on that thin ice, there's a real danger you'll fall into. So if you go into this work, you've got to be anchored to the shore. You can reach out one hand to the person in the water, she cautioned, but your other hand needs to have a firm grip on the people and things that connect you to the shore. If you don't, you lose the people who are your patients and you lose yourself. I chose that passage because I think it really does speak to the common territory that we all have, regardless of our diagnoses or lack thereof. And also for those of you who are really engaged in the care of people who are mentally ill, a reminder that that all of us at all stages have to keep those anchors to the shore as well. My thought might be at this point to give you a little bit of a break from hearing from me, though I always have plenty to say. My children would be the first to tell you. I'm happy to give a dissertation when just a simple yes or no answer would suffice. But I think at this moment, if it sounds good to others, we can go ahead and move into other portions of our evening where the discussion broadens and opens up a bit, and then I'll just go where I'm told after that.
Thank you, Dr. Montross, so much. I really appreciate the abiding with and that second passage, especially that you read, because, you know, at some point, it's accepting that what is and just being there with what is. So that resonated with me a lot. So next on the program, what we're going to do is we're going to have a short Q&A with Dr. Montross, and also Our peer navigator, Linda Stedman, and I will be standing by if there's a question on a local scale that we could answer. So I'll introduce myself and then I'll let Linda introduce herself. I'm Wendy O'Leary. I'm the Impact Director at Connect Summit County. And one of the things that I do for Connect is oversee our peer navigation services. So we have peers, people who have a lived experience of their own mental health challenge or being a primary caregiver of somebody with a mental health challenge. They have the lived experience of trying to find and navigate resources. And our peer navigators help other people find the resources and help and support that they need in our community. We also have an online mental health resource directory and a provider database. We have toolkits on our website with timely topics, relevant topics to people who are searching for answers. And we do a lot of community mapping, and so we have a community resource guide. So Connect Summit County really is actively on the ground, boots on the ground, helping people find what they need when they are faced with behavioral health or mental health challenges. And so I'm going to have Linda introduce herself, and then we'll go into a Q&A. And if you have questions, please put them in the chat for Dr. Montross, and Linda is also happy to answer questions about local resources.
Wendy, there's already one in there about anosognosia, so they are coming in.
Okay, great. Thanks.
Hi, I'm Linda Stedman, and I am what we call a peer navigation specialist. So when someone is trying to find help with mental health issues, they can call our resources line and I will answer. And that's the English line. We also have a Spanish speaking line, and that person couldn't be on the Zoom event today, but she's available for Spanish speaking people looking for help. So I help people by talking with them on the phone. I email with them, and I also text with them. And I listened for a while. I think it's really important to listen to what's going on with someone and help them feel like they're not alone. And they're also talking to someone who's been through similar experience, because it's a pretty isolating thing sometimes. And I love what you said, Dr. Montross, about, I love the abide part too, but also the awful experience of trying to get help, and you have to do this emergency thing all the time. So anyway, we're here to help in a different way, and I just feel grateful I'm able to do this job and help people in ways that I needed when my family was going through these kinds of experiences. So thank you. And anybody out there, you're welcome to call us.
Thank you, Linda. Dr. Montross, we have a question that came in the chat that says, would you take a moment to discuss your take on anosognosia and how you address and manage this within your practice?
I love speaking to an educated group. You've got the terminology and everything. So for anyone who does not know, that's a term that means that a person really lacks an awareness of their own symptoms. So what we see most frequently is in a case like Colin's, like I described, where someone doesn't see an issue at all with the experience that they're going through, or I often really feel as though this is common in patients with delusions. If someone is very paranoid or really believes that they're in danger of some kind, that they're being spied on in some way, or that their food is being poisoned, or that their grandchildren are at risk, you can talk till you're blue in the face trying to convince them that that is not the case, but there's really a deep-seated fear and certainty about it that it is quite difficult to penetrate. So I think it is one of the major challenges in psychiatric treatment. And when I made that comment about the decision-making organ being the affected organ, that's very much what we see. So there's no hard and fast way to penetrate that. I think I have my own style in those moments of talking to people. Often I do a lot of listening, as Linda said. I really try to hear what their particular circumstances are, why they are resisting the idea that that what other people are saying is really not what they're experiencing. If there are opportunities, not to argue with them about it, but to sort of point out differences in what other people are seeing or experiencing versus what you're experiencing, and how can we think about those. I try to provide them to patients. Oftentimes that doesn't do much. And so what I try most to reflect is the worry that people, including myself, have for them. So I will often say, I know you really feel that things are going fine for you right now, but I've also talked to your family. They're very concerned about you. I'm pretty concerned about you. And if someone has had a period of time of mental illness in the past, it can be helpful to draw on their past experience. Again, something they themselves can relate to, or you can say, you had a period of time where you weren't thinking as clearly as you always do in the past. And those people shared those same concerns then. I think that's how they're feeling now. But none of these things are foolproof, and it poses a real challenge. And I think especially the place where I see this especially is the parents of young adult children. So when 18, 19, 20, 21-year-olds are considered adults and completely responsible for their own care, and they don't, clinicians don't even have the right to speak to parents if the 18, 19, 20-year-old does not give them permission to do so. I think that can be really, really crushing for parents and a very difficult thing to navigate. So again, reflecting to the patient how much he or she is cared about and how much of this lies in concern, and then finding any kinds of ways to pair with the person and ally with them, as opposed to kind of doing this and trying to argue them out of it. But it's a real challenge. I think I may come down slightly on a firmer side of controversy here, in terms of saying that I do think there are times when people should be hospitalized against their will, or medicated against their will. And for me, those are moments when the argument about autonomy has really, in my mind, gone off the rails. So if someone is saying to me that a person really has the right to live under an overpass and feel terrified and afraid and paranoid, and their homelessness because of their symptomatology, that to me is the wrong thing for us to be advocating for people's mental wellness. So I think there has been a correct swing toward patient advocacy after the kind of draconian practices in the 50s and 60s. But I think some of the things that we're advocating for in terms of autonomy beyond all else really loses sight of the fact that people suffer. So if we're arguing for autonomy as the pinnacle, as sort of the most important goal, I think there are lives that get lost this way by people who exist in a state that they themselves would not actually want to exist in if they were thinking clearly. So that's a controversial stance, but I've seen too many people suffer for prolonged periods of time. And then when they finally accept medication or are court ordered to medication and begin thinking clearly, they look back on the way that they had been living their lives and really grieve the stretch of time that was lost. That was a long answer to the first question.
Thank you. There's another one in the chat. Your book was written in 2013. What would you say has improved, and what would you say has become more problematic within the mental health system since then?
Mm-hmm. So as we are seeing in the pandemic, science only moves forward, which is a gift in my profession. So, the treatments we have available for mental illness are only getting better. And so I think that I am really heartened by that, and not just medications, though certainly there continue to be new developments in medications, new breakthroughs in medications, but also in some more physical treatments and transmagnetic stimulation and even in a new understanding of older treatments like ECT. So I think that gives me a lot of hope. We're always learning more, and we're learning more in leaps and bounds about mental illness and our ability to care for it. The thing that has gotten worse, and this is a real trend that was certainly in place in 2013, but has worsened since that time, is that we just keep slashing funds. We keep cutting money over and over again. For mental health care, and that has really catastrophic consequences. It's not economically wise. Emergency room visits and inpatient hospitalizations. One inpatient hospitalization easily costs more than a year of private psychotherapy and psychiatric treatment would. So it's short-sighted from an economic standpoint, but also people's lives are really profoundly affected by it. In writing Waiting for an Echo, I often saw and heard stories of police encounters with people with mental illness. And I'll just share one anecdote that's relevant, I think, to this question. One was a story at the Portland, Oregon waterfront, where a man had a gallon jug filled with fluid attached to a chain, and he was swinging this gallon above his head and charging at people. He was clearly mentally ill. People were afraid. They called the police, and I spoke with the police commander about this particular example. And she said over the course of 2 hours, the officers worked with the man without any kind of violence, got him into their car, took him to the hospital emergency room. And she said there were no beds in the hospital, no psych beds in the hospital. And her quote to me was, he was discharged from the emergency room before the officers were done with their paperwork. So the man went back to the waterfront, started again, swinging the gallon jug above his head. Police were called, and this time they took him to jail. And so I think one of the consequences of the slashing of funds is not just that people are in crisis more often. It also means that people don't have access to the treatment even the emergency treatment that they need. And we're seeing this in Rhode Island right now, as I think is true across the country, with children who are really in crisis during the pandemic. We have 40 children right now holding in our medical hospital, waiting for psychiatric beds. So those are children who, adolescents are being profoundly affected right now by the pandemic and the social isolation and costs of that. And those are kids that the doctors have deemed not safe enough to go home. So 40 children for whom there are no beds in the state are waiting at medical hospitals. So I think funding has just been on a steady slide, and that has human consequences. When people end up in punitive environments instead of therapeutic ones, or they don't get the care that they need, that has real consequences.
Agree.
Wow. We had another one that might tie into that well. Do you find that trauma underlies some mental illness diagnosis? And if so, do you address the trauma as part of the recovery process?
Yeah, for so many people that I see, trauma is a component of their experience, and there's so many different reasons for this, right? That sometimes people who have mental illness are in more vulnerable circumstances as a result. That they don't have the social supports, educational supports, work supports always in place if they have severe symptoms of mental illness or if they struggle with addiction. For some people, the trauma has really been present from an early stage as well. So certainly, one of the things that I love about psychiatry that also makes it a real challenge is there's not an easy fix for every one person with depression is not the same as the next person with depression, so unlike going to the hospital with chest pain, where they can test your cardiac enzymes and they can run a stent if they need to, and do an echo and get a picture of your heart, we don't have pictures, we don't have CAT scans or MRIs that show us where the locus of pain is. We don't have blood tests that tell us that you have schizophrenia or you have depression or you have post-traumatic stress disorder. So we really have to just listen and ask questions and hear the stories and the lived experiences of people and hear how those things are affecting them still today. If indeed they are. Some of my patients have endured incredible traumas and feel as if that's in their past and they've moved beyond it. Many, many people have ongoing symptoms that they carry forth with them. And what we see is, just like so many other stresses for so many of us, is that there are periods of time where those things interplay, right? The symptoms of sadness and depression and drinking too much, and then the history of the trauma may come together in a way that really is why someone presents at the hospital and feels suicidal. It's not so simple as just saying, I'm here because I have depression. So we do a disservice when we don't acknowledge the trauma that people share with us, and also recognize that for many people, there's trauma beneath the surface that they don't share as well. So that is really important. In my work, in my inpatient work, people are often there for a very brief period of time. Again, that's often financially driven. We've really moved in this country to a model of acute care in hospitals. So people's average stay is 5 to 7 days in my hospital. So there might be some interaction with that, with a trauma history with someone, but in a careful way, right? Because you're not going to be able to really hold intensive trauma work in that short period of time. So the goal then often is to have some trauma-informed treatment that that continues after the period of discharge.
Thanks. Are you familiar with any new and promising practices in psychiatry and/or the behavioral health field, including ketamine therapy, transcranial magnetic stimulation, or psychedelic therapies?
Yeah, so I'm watching all of these things with great interest. I think ketamine in particular is getting a lot of attention right now. People are looking at it in studies around war trauma, around traumatic memories, around acute administration for easing depressive symptoms. I think it's fascinating. So I'm very excited to see where it leads. Also, I have realism, because there have been other periods of time even in my career, where we were very excited about PET scans or different kinds of brain scans that might reveal to us new pathways for treatment that haven't really panned out in the way that the Holy Grail that we hoped. So I maintain both a consistent optimism and exuberance about new treatments, and also a kind of dose of tempered skepticism to see how in fact they play out when they are tried on large groups of people in good studies. But I think there's so much left to learn about the brain, and there's so many aspects of it that we have a limited understanding of, that to me feels very exciting in terms of the places where we still have an opportunity to go. So I have a lot of confidence that mental health treatments will only continue to improve. But I do think it's important to recognize, just as we were talking about in the last question, that there are, that there are pieces of this that are experiential, right? The people endure things, or they have, social stressors that are going on in their environment at the moment that really are disconnected from their neurochemistry, or disconnected from their family history of mental illness. So again, one of the things that is both wonderful and kind of infuriating about psychiatry is that people are not just a collection of gears or chemicals, right? That they're complex beings, and many different things, we all know, many different things contribute to our sense of happiness, of security, of stability, of clarity of thought. That's true for all of us. So always yes on the excitement about hopeful things to come, and an acknowledgement that it's complicated.
Great, thank you. Wendy had a great question. Can you please speak more to the differences in neurology and psychiatry that you touch on in your book? And specifically, can you speak to whether or not you view the brain as a distinct or different from the mind? And if so, how do they interact? And if you need to read it, it's in the chat. I know it was very wordy.
I love that question. And in some ways, the book was really wrestling with some of this. I think, so to start at the top of the question without looking at it, to start at the top, neurology is really about dysfunctions of the brain in particular. So this would be the realm of of epileptic seizures, of motor neuron disease, so Lou Gehrig's disease, ALS, movement disorders, Parkinson's, so diseases that really have a neurologic origin to them, stroke, traumatic brain injury. Often, and so psychiatry would be more the mental illnesses, the schizophrenia, bipolar disorder, depression, those anxiety disorders. So that's the way that it would be kind of divided most in a binary way. The reality, of course, is that there's lots of overlap between the two fields, and part of that overlap is that we've made those fields up, right? That the human body does not come with neurologic parts and psychiatric parts. We, in our attempt to delineate and describe symptoms and conditions, we've made that division, and so it can be a false division sometimes. Anyone who knows someone who has had a traumatic brain injury knows that there are neurologic symptoms and there are psychological symptoms, and those things are very much a result of the same injury in the same part of the brain, or maybe different parts of the brain, but the same injury can cause symptoms in both of those realms. It's certainly also true in something like dementia or Parkinson's. There's a tremendous amount of overlap. There can be mood symptoms along with neurologic symptoms. So I think in a distinct way, people would say that the neurologists are more apt to treat those things that do come up on the pictures, the mass that you see in the brain, the stroke lesion that you see, something that you can test for in the blood or in the muscle, and that the psychiatrists are treating the things that you can't so easily see. So yeah, is psychiatry more the realm of the mind? Yes, but also the realm of the brain. So I think maybe more than mind, I think of the self. And I think so much of our brain is so deeply connected to how we perceive our sense of ourselves, our identity, really. The first book I wrote was about the experience of dissecting a cadaver in medical school, and I write in that book about holding the brain of our donor in my hands and thinking, this had memories in it. This had a spunky personality that came from this organ. This had a person's sense of self. And so mind, yes, but also identity. And I think that we do wrong in psychiatry if we don't prioritize the importance of that when people come to us with symptoms of illness, what they really want is to be seen as themselves and to be a healthy, strong version of themselves. And so I'm often less concerned with the precise diagnosis or the, alleviating one particular symptom as much as I am trying to get a person in a place where they feel generally stronger, safer, steadier, more themselves.
Thank you. And everyone can feel free to type some questions in as well. We have until 5:15, so don't feel like we are on a time crunch. Do you have any thoughts on, quote, alternative treatment for serious mental illness that don't involve medication, with the understanding that medication is needed for certain patients?
Sure. So there are all kinds of things that are helpful in addition to or apart from medication. And so, for example, there are people in my life who I know well who have bipolar disorder, for whom medication is one important part of their treatment, but it's also critically important for them that they are on a sleep schedule that's very regimented, that they're on purpose about not getting too much stress in their lives. So they, one of my dear friends has a very strict meditation practice. So I think that there are certainly, medicine is not the only answer by any stretch of the imagination. Medicine can be an answer and can really help alleviate certain symptoms that really do seem to be helped or hindered by neurochemistry. But there are other pieces that affect our neurochemistry as well. We know stress affects our neurochemistry. We know the lack of sleep affects our neurochemistry. We know the nutrition that we put in our body can affect that as well. Hormonal imbalances certainly can do the same. So I am wary of, and this is, you know, my house is in the allopathic medicine house. So I'm wary of, you know, supplements that aren't regulated by the FDA, and homeopathic remedies that aren't really proven. But I'm certainly a big believer in exercise and nutrition and sleep and, you know, massage and mindfulness and yoga and anything that helps people really, and also I think those things can help give people agency in their own illness in a way as well, where people understand that the medication is part of it, and me taking the medication is an action that I am doing to give myself agency, but also there are these other things that I have quite a bit of control over that are my own agency in this situation as well. So yeah, I'm certainly not a person who believes that the pill is the lone answer to everything.
Thanks. Some states and counties have a full-time social worker at the main jails. It has been a very different experience for my son in the state of Colorado that does have one in a positive way. How long before this will occur in every state, county, and jail?
Yeah, so I have spent so much time on these questions in my new book, and how long until a very long time. So I think that you know, the trajectory of my own writing has taken this trajectory where the book I wrote about dissection was really kind of a memoir, and some history of medicine and kind of a poetic piece about that kind of reckoning with the mortality of dissecting a dead body and going from non-doctor to doctor. Falling into the fire was as I said, kind of bearing witness to the struggles that my patients were dealing with and some of the questions of psychiatry. But it began for me a little bit of a sense of advocacy as a writer, that when people would really try to differentiate between, you know, those people with mental illness are really different than me, than my family. You know, I felt kind of indignant and really wanting to push back. Or when people would say like healthcare is not important, people don't need it, I really got a little angry. And I think that advocacy has really become a central part of the new book, Waiting for an Echo, because I do competency to stand trial evaluation. So that's when a judge or a defense attorney has enough concerns about someone who's been accused of a crime. They've not been found guilty of anything. They're pretrial detainees, but either the defense attorney or the judge has a concern that they're not going to be able to understand their charges or understand how court works or work with their attorney. And so they ask me to do a psychological evaluation to make sure that they can fairly participate in the process. And one of the things that was most striking to me when I first began this work was that if you had plunked down for me a set of patients from my hospital and a set of people that I was evaluating in the jail and stripped any kind of recognizable cues from the environment, I would not have been able to tell the people apart. That there was not a way for me to distinguish between the people who were in correctional facilities that I was seeing and people who I was seeing in my hospital unit. And many of my patients describe the same things that detainees describe, which is coming into contact with police because of their symptoms. They're shouting in a Starbucks, or they're charging through TSA because they're paranoid, or crimes of addiction, for example. So there's a great need for this, and so the reason I tell you the advocacy story is I think that there's not going to be a social worker in every jail until we demand that there's a social worker in every jail. And I think there are going to be police as the first response to psychiatric emergencies until we stand up and say that's not fair and that's not just. And that means that we have to elect people who are going to fund these positions and who are going to fund more psychiatric treatment, more psychiatric beds. So the question of how long will it be, I think really depends on how much traction those of us can get who are saying this is not what we think our justice system in this country should look like. We don't think people who are ill should be in a punitive facility. We think they should be in a healthcare facility as well. Or if there's a, there are some diversion programs that's in some courts, but certainly not in all the courts, where people with mental illness can be diverted to treatment instead of jail. But that's not at all universal. So I think the more that we really ask these questions and insist that the way forward is not being tough on crime. The way forward is being realistic about crime and really and being individualized about crime and trying to understand what's going on for people when they commit crimes. We have to insist upon that when we go to the polling places.
Wow, thank you. Okay, I have a long one. Looking back at my son when he was younger, he did not have his first psychotic break until he was 16, but there were oddities compared to our next child. It was our first time, so we didn't know. For example, he had a hard time respecting boundaries. He wet his bed until 13 and a half, and he was socially awkward, etc. I wonder now if we could have done anything to help him earlier as a way to help others moving forward.
So what what I hear in that question is what I hear so often from parents of young people who have psychotic breaks, which is, could I have seen this earlier? Could I have intervened? Could I have done something different that would have changed the outcome? And I think we hear that in parents of kids who have all kinds of mental illnesses. We certainly hear that in parents of kids who have committed suicide, for sure. I think that particularly in psychotic illnesses, there is, well, I'm not speaking specifically to this person because I can't speak specifically to this person, but in the patients that I have seen and in what I know about an illness like schizophrenia, for example, there's not a parental intervention that could have been done to change that trajectory. And even at this stage in our understanding of psychotic illnesses, even there's not a version of early intervention that we know makes a real difference in the early stages. If someone who had a psychotic break at 16 might have gotten some kind of treatment at 14, we don't really have evidence that would make a difference. We do have some evidence about the importance of treating first psychotic breaks, and that the duration of first psychotic breaks, the longer that those last and the longer that those go untreated, can have some predictive value, can have some meaningful predictive value to how the illness progresses. But I would say my overwhelming response that I'm having right now is just don't be hard on yourself. That parents feel so powerless when these things fall upon their kids, and there's no use in thinking back about, could I have done something differently? Because I would say the answer is no. And continuing to stand by your child and love your child and appreciate even those oddities is the most valuable thing, I think, going forward. But I hate that for parents. I know that tendency to say now in retrospect, I see this thing that should have cued me in. I see this thing that should have cued me in. And the reality is, especially for teenagers with psychotic breaks, no one has that on their radar. No one expects that to happen. So it's never something that you could anticipate. And even if you did, I'm not sure we're at a stage where it would have made any difference.
Wow, thank you so much. We have about 5 more minutes, so I'll just ask a couple more questions if you don't mind. What can you say to family members about how they can help you, the doctor, especially when the patient is in crisis?
Information is always helpful. When I see patients, it's often for an abbreviated period of time, and parents sometimes have a comprehensive understanding of medications that have worked and not worked, personality characteristics. My kid is not going to listen to you if you talk to him or her in this way or about this. Things that the patient cares about or that are important to him or her, successes that they found, not just the things that have been challenges, but also ways in strengths that the person may have that will really help them going forward. So I think just information, that person so much better than we're going to know them in a short period of time. So communicating openly things that you think are helpful, I think is incredibly valuable.
Thank you. What do you think it would take to make it standard operating procedure to treat all newly presenting symptoms of mental illness by first beginning with a complete physical workup, including checking for allergies, heavy metals, nutritional deficiencies, brain and gut health, etc., and other organic disorders of the brain, especially for children and teens, before prescribing psychiatric medications?
Yeah, that's a question that I think people are looking at in different realms. I think there are competing things here. Of course, as a physician, you don't want to be missing something. Um, the beautiful book by my friend Susanna Cahalan, Brain on Fire, really masterfully articulates how we can get it wrong in psychiatry, and that's a book that I would just widely recommend to people. Her experience of having an encephalitis that was really interpreted as a psychiatric illness, and was not, though she had psychotic symptoms as a result. And she talks openly about the fact that she could have been on a path where that went unrecognized and untreated, and could have had a lifelong psychotic illness and diagnosis. So there are those instances where, that we psychiatrists live in terror of, that we might be missing something. On the other hand, it's not pragmatic, nor is it really, I think, useful to, if we see symptoms that are really consistent with things we've seen before, to cast an extraordinarily broad net. So I do think for first psychotic symptoms, a neurologic workup is absolutely merited. If someone goes from not having psychotic symptoms to having psychotic symptoms, particularly as a young person with the absence of anything else, I think it's due diligence to do a basic neurologic workup. I don't think that, in my experience, I'm not sure that that I would lump in the totality of that list, partially also because, again, I think some of those are awfully low yield, and any resources and time that we spend on things that are less likely take away from the things that are more likely. We have a saying in medicine that when you hear hoofbeats, you think horses, not zebras. And I think even though there are the moments of the zebra, which we have to be aware of, that really we provide the best help to the most people by focusing on horses. And so that's not to say that people shouldn't chase down whatever feels necessary to them, but I would say that the utility of some of those things makes sense to me, and the utility of just casting a super wide net, I think we're beyond that as a scientific discipline at this moment.
Thank you. All right. I think this is our last question. Is it true that parents of adult children with SMI can communicate with the doctor and share the information you just spoke of to the doctor, even if their child doesn't sign a release of information?
Yeah, so my understanding, and what I've learned working in legal situations like the jails and prisons, is that every state has different laws. My understanding of the laws where the laws where I practice, and my understanding of the laws more generally, is clinicians can always listen. That there's nothing that prevents you from a parent calling up the clinician and having the clinician on the phone, and you telling your experience and your information. We are often not in a position, without a release, we're not in a position to give information back to you. We're not even allowed to confirm or deny that the person is in the hospital. But if you call to ask to the doctor that is treating your child, and then in Rhode Island, certainly the doctor can be on that phone listening to what you have to say, and that's not that's not a breach of protocol. And I just saw a flash, what is with SMI, and I'm assuming serious mental illness or severe mental illness was the abbreviation. So yeah. I know our time is at a close, and I know that you're gonna you're well in control of the evening. But before we get to that stage, I just want to say how much I've enjoyed the evening tonight. These are such high level questions that really demonstrate to me the engagement of this community and the knowledge base of this community, and that's exciting. And Park City is lucky to have a group of people with this degree of passion and knowledge working for those in your community with mental illness. So thank you for spotlighting Mental Health Awareness Month, and thank you for hosting me. And I'm very, very glad to know about Connect Summit County.
Thank you, Dr. Montross. Thank you to Frank and Wendy and Linda and Dr. Montross all for being here tonight. Now I will turn the time over to Rachel Reddick.
Yeah, hi guys. I am Rachel Reddick. I'm the development director with Connect Summit County, and I'm just gonna say a few words to wrap up. So first, I just wanna extend a really heartfelt thank you to Healthy You, Park City Community Church, Esta Pizza, Hyatt Centric, and Northwestern Mutual for sponsoring Mental Health Awareness Month. Their generous support really does give us the resources that we need to make a big impact on the mental health in our community so we can keep having these excellent conversations. This closing slide that we have here, are you struggling right now? So we have peer navigation that we mentioned earlier. Our peer navigation resources are available in our community and are always evolving. And our trained peer navigators can help anyone find the resources, support, and information that they need. So you can call our English line at 435-776 HELP or 4357. And then the Spanish line is 435-655-1230. And just keep in mind that these are not crisis resources. These are just to help get you started on your journey if you've recently come in with a diagnosis or something like that. If you are in crisis, we have other crisis information available, including the MCOT, which is the mobile crisis outreach team that we have in Summit and Wasatch counties. These resources, I believe, are available Monday through Friday. So it's not full-time yet, but I think they are hoping to get it into full-time services. And to everyone who tuned in today, we really appreciate you attending today's event. If you have feedback, please click the feedback form in the chat. We want to continue to improve our events, and so we really value your input on how we could do that. And then I'd also just like to say that, you know, Connect Summit County brings together residents in our community who are concerned about mental health challenges facing our community. All of Connect's events are free for the public to attend. So if you can and would like to contribute to Connect Summit County, please follow the donation link in the chat or go to connectsummitcounty.org and click donate. Your generous support can make a really big difference in the events that we can hold, in the people that we serve in Summit County, and just in our community as a whole. And if you're taking something really specific and valuable away from this event and you want to help sustain our work for the future, consider giving monthly. It really does make a big impact in what we can accomplish. So thank you, everyone. Thank you, Dr. Montross. And I hope everyone has a great rest of their day and a great Mental Health Awareness Month.